Hello everyone, and welcome to today's webinar where we will be discussing the systems of care in ACLS. The AHA guidelines describe systems of care as a separate and important part of ACLS provider training. These systems of care describe the organization of professionals necessary to achieve the best possible result for a given individual's circumstances. They include an overview of the ways life-saving interventions should be organized to ensure they are delivering efficiently and effectively. Hospitals, EMS staff, and communities that follow comprehensive systems of care demonstrate better outcomes for their patients than those who do not. Some things to know is that management of life-threatening emergencies requires the integration of a multidisciplinary team that can involve rapid response teams, or RRTs, cardiac arrest teams, and intensive care specialists to increase survival rates. 2015 guidelines update reflects research that shows that RRTs improve outcomes. Successful cardiopulmonary resuscitation requires the use of it as part of a system of care called the chain of survival. As with any chain, it is only as strong as its weakest link. Thus, everyone must strive to make sure each link is strong. For instance, community leaders can work to increase awareness of the signs and symptoms of cardiac arrest and make AEDs available in public places. EMS crews must stay abreast of updates and innovations in resuscitation and hone the skills required to deliver CPR quickly and effectively. Hospitals should be ready to receive patients in cardiac arrest and provide excellent care. Critical care and reperfusion centers should be staffed by experts and equipped with the latest technology. Integrated post-cardiac arrest care is the last link in the adult chain of survival. The quality of this care is critical to providing resuscitated individuals with the best possible results. When the interventions below are provided, there is an increased likelihood of survival. And these are the interventions. So, one of the interventions is therapeutic hypothermia, which is recommended for comatose individuals with the return of spontaneous circulation after a cardiac arrest event. In therapeutic hypothermia, individuals should be cooled to 89.6 to 93.2 degrees Fahrenheit or 32 to 36 degrees Celsius for at least 24 hours. Another intervention is optimization of hemodynamics and ventilation. 100% oxygen is acceptable for early intervention, but not for extended periods of time. Oxygen should be titrated so that the individual's pulse oximetry is greater than 94% to avoid oxygen toxicity. Do not overventilate to provide potential adverse hemodynamic effects. Ventilation rates of 10 to 12 breaths per minute to achieve EtCO2 at 35 to 40. And IV fluids and vasoactive medication should be titrated for hemodynamic stability. Percutaneous coronary intervention is preferred over thrombolytics. Individuals should be taken by EMS directly to a hospital that performs PCI. If the individual is delivered to a center that only delivers thrombolytics, they should be transferred to a center that offers PCI if time permits. Neurological care. Neurological assessment is key, especially when withdrawing care for brain death, to decrease false positive rates. Specialty consultation should be obtained to monitor neurological signs and symptoms throughout the post-resuscitation period. Don't forget, we offer online ACLS certification on our site. You can find a link in the description. We encourage you to become certified as soon as possible, whether that be on your own time with an online course or in an in-classroom setting. So thank you so much for tuning into today's webinar. We will catch you next time.